Hi, I'm Megan Melody from Tampa General Hospital, and I'm here with SOHO Insider Podcast and Dr. Tycel Phillips from City of Hope Cancer Center.
Thank you.
And today we're going to be talking about some of the latest breaking work in mantle cell lymphoma published by the very own Dr. Tycel Phillips. So thank you for being here today.
Thank you for having me. It was a pleasure.
Yeah. So you have really paved the way for the use of bispecific antibodies in mantle cell lymphoma, publishing some of the earliest data that we have in this patient population. I'm particularly interested in your paper in JCO, the phase 1/2 clinical trial looking at glofitamab in mantle cell lymphoma. I was wondering if you could tell me a little bit more about your study.
Yeah, so this study was an offshoot of the original 197 study, which was mainly focused on large cell lymphoma and follicular lymphoma. So as the initial phase 1 part had a few mantle cell lymphoma patients that had good outcomes, they did make an expansion cohort for that patient population. And so in the context of running the study, we were able to evaluate a couple of different things. As been a whole, bispecifics have been a little bit harder to introduce into the mantle cell lymphoma patient population. But so with this one, they went about it in a bit of a unique way. So as we know, obinutuzumab has been very helpful in reducing some of the CRS risk with glofitamab. And 1,000 milligrams is the typical dose we see with large cell lymphoma. So in the mantle cell lymphoma patient space, we did look at the difference between 1,000 and 2,000 grams prior to the given glofitamab in MCL patients. More so because, again, Genentech has some internal data suggesting that the mantle cell lymphoma patients had a higher clearance rate of obinutuzumab than what we see with large cell lymphoma patients. So they were curious if the higher dose would actually cause more competitive binding and maybe reduce some of the CRS risk. During the context of the study, we did sort of see that was the case, that the higher dose of obinutuzumab actually made it much safer and easier for us to give glofitamab in this patient population. So that was something that came out of that study. And moving forward into the ongoing phase 3 study, something that's implemented to try to reduce the rates of CRS, which again has been the biggest issue with sort of integration of bispecific antibodies. Is I think all of the bispecifics as single agents have run into quite a bit of issues with CRS, likely due to the amount of circulating mantle cell lymphoma that's probably present in the peripheral blood. Thereafter, after that patient population, going through the traditional step-up dosing, 2.5, 10, and then eventually settling on the 30 milligram dose. We did see quite impressive overall response rate, duration of response, especially in those with patients who actually maintained and kept a complete response through the end of treatment. So looking at those who actually received the 12 cycles and maintained a complete remission, the duration of response, or duration of complete response, should I say, for that one, has been fairly impressive. Unfortunately, there were quite a few number of patients, as this was conducted during the COVID pandemic, that unfortunately died in a complete response. Which invariably has impacted the progression-free survival and also the duration of complete response of these patients. But as we take this as a whole and looking at how this patient population behaves, even in those who have previously failed a BTK inhibitor, I think we were all quite impressed and happy with the results from glofitamab. And it does provide an alternative, again, to CAR T-cell therapy for this patient population, given that, at least with glofitamab, there isn't a necessarily need to sort of relocate to a CAR T center, and it's readily available off the shelf. Now, that doesn't necessarily counter the reluctance we may have in some community settings about introducing bispecifics. But I think as we get more community settings sort of comfortable using bispecific antibodies, this will eventually provide a good option in lieu of CAR T-cell therapy for those who can't or just don't want to go to CAR T for patients with mantle cell lymphoma.
Oh, thank you. That's really fascinating and really impressive work. I actually, had read the paper and didn't realize such profound findings regarding the obinutuzumab dosing. I guess I'm wondering, in other disease states, particularly as we're exploring bispecifics and CLL, if you think that this sort of lymphodepletion or sort of priming with obinutuzumab at a higher dose is something we should be applying to or looking at least in other disease states and probably even with other bispecific antibodies.
So I think you hit the nail on the head there with your first statement. It's just basically the lymphodepletion or clearance of circulating B cells, malignant or otherwise. I think that is the crux that will likely help with some of these other B cell malignancies, especially like CLL. So if you can have a way to clear out the peripheral blood, reduce the amount of disease bulk, and then introduce a bispecific later, I think that will allow us to get the bispecifics into many more patients across the board. So I think if we look at how things have been sort of administered, like the SkyGlow study, different disease, but same sort of concept, a couple cycles of a polar chip, reduce the amount of disease there, then introduce the bispecific antibody in a way to reduce the rate of cytokine release syndrome in this patient population. So the mantle cell we did with venetoclax, are there other agents we can hopefully utilize in that patient space to sort of reduce the amount of disease? CLL, again, I think you have other options such as the BTK inhibitors, the non-covalent ones, maybe the BCL2 inhibitors, sonrotoclax or venetoclax. In large cell lymphoma, if you can still get some chemosensitivity, again, these are things that can slowly help reduce the amount of disease burden to allow safe entry of the bispecifics.
Yeah, and I think you really touched on an amazing point earlier in our talk that, in particular, I think we're surprisingly seeing a lot more CRS and treatment-related toxicities in those in particular with a lot of circulating disease, which obviously as these treatments move into different disease subtypes, we're starting to notice this pattern. And then I really appreciate the segue because the next thing I was going to ask you about is speaking about novel agents in the treatment of lymphoma. You have been kind of leading the charge in examining the use of venetoclax in B-cell lymphoma. You have multiple papers published in the application of this. And so I guess I was just wondering if you could tell me a little bit more about your work in examining the use of venetoclax in relapsed refractory non-Hodgkin's B-cell lymphoma.
Yeah, so I think the paramount for the study was the InHarmony sort of platform that came out of Genentech. So basically looking at various ways to use venetoclax and some of the other agents. In this particular aspect was polituzumab and patients with relapsed refractory large cell lymphoma and relapsed refractory follicular lymphoma. Ideally to sort of see if this novel combination has some sort of legs in this patient population. So what we saw with this situation, obviously there is some synergy because again, there's some data that suggests that venetoclax may work as an MCL1 inhibitor. What it sort of introduces in the polituzumab, I apologize, acts so much as an MCL1 inhibitor. And then you combine that with the BCL2 inhibitor venetoclax to get some sort of synergistic anti-apoptotic sort of destruction for the tumor. So we did see some decent efficacy, I would say, in large cell lymphoma, but obviously it's a very tough space and given the toxicity and sort of the evolving field, didn't necessarily make sense in that patient population. But in the follicular lymphoma patients, we did see some improved efficacy and outcomes, and polituzumab as a whole hasn't really been shown as a single agent to be very effective in follicular lymphoma. But with the addition of the venetoclax, and again, we had some modest safety issues, but nothing significantly concerning. The biggest thing would be neutropenia. We did see some durable efficacy in the patient population with follicular lymphoma. But again, I think with the introduction of bispecific antibodies and then some of the other things that have come along, obviously it sort of has pushed that sort of to the wayside. Still an option there. I mean, people need it, but I think for the most part, with some of the other drugs that we have right now, probably not something that will be sort of a big player in the follicular lymphoma space. Given, like I say, bispecifics, and now we have TAFR squared, and then we have a couple other agents coming down the line.
I mean, it's a pretty good problem to have that you have this, combination regimen that's showing efficacy in follicular lymphoma and pretty good efficacy, and that it still isn't quite as good as some of these other emerging therapies. So I think it's a really exciting time in the field of B-cell lymphoma, and I really appreciate the vast amount of literature you contributed to this space this year. So thank you very much for taking the time to speak with me about it.
Thank you. It's my pleasure. Always willing to come back.
Thank you.
Thank you.